You ever think about how much absolute blind faith goes into the spatial reasoning of a surgeon?
Oh, all the time. I mean, it's wild.
Right, because we have this tendency to picture the operating room as this, I don't know, this brightly lit arena where everything is just laid bare and completely visible to the doctor.
Yeah, like some high-definition broadcast of the human body.
Exactly. But when you dig into these urology manuals and the advanced surgical guidelines, which is the mission of our deep dive today, by the way, we're unpacking this huge stack of medical protocols.
And it is a dense stack of protocols, let me tell you.
It really is.
Yeah.
But you realize reading through it that they are effectively doing high-stakes structural engineering, like in the dark.
It's an incredibly unforgiving environment, for sure. You're operating in a world where the margin between clinical success and, just catastrophic failure is measured in fractions of a millimeter.
Wow, fractions of a millimeter.
Yeah, and in urology specifically, knowing exactly the trajectory of your instrument, like the raw geometry of your approach, is often way more critical than the actual therapeutic agent you're injecting.
And what immediately jumps out from the data for you listening at home is this terrifying vulnerability at what they call the 12 o'clock position of the urethra.
Right, the 12 o'clock danger zone.
Yeah, because when you look at the intraoperative complication rates for things like AUS placements, those artificial urinary sphincters, the urethral perforations aren't happening randomly.
No, they are highly concentrated.
They're overwhelmingly clustered dead center at 12 o'clock, which makes you stop and wonder, if the whole circumference of the tissue is exposed during the dissection, why is that specific coordinate an absolute danger zone?
Well, the issue at 12 o'clock is entirely mechanical, actually, and it dictates the entire geometry of urological surgery.
Okay, let's unpack this. Why is it so mechanical?
Because the urethra at that specific position is rigidly tethered to the corpora, the corpus cavernosum. So it has zero mobility right there.
Right, so it's basic physics. It's like the difference between striking a loose pipe hanging in a basement versus one that's bolted directly to a steel beam.
That is exactly it. I mean, the
Right.
loose pipe, it dissipates the kinetic energy of the impact by moving, it just yields.
It wiggles out of the way.
Right. But the bolted pipe, the 12 o'clock position, in this case, it takes the full focal impact of the force.
Yeah.
Because it's locked against the corpora, any direct contact from a surgical tool, any instrumental crushing, or even thermal spread from a cautery device just has nowhere to go.
The tissue just absorbs all that trauma and tear.
Exactly. It just punctures. And if we connect this to the bigger picture, recognizing this rigid tethering at 12 o'clock is what dictates the entire approach to how urologists insert instruments and needles.
So the lack of mobility is the massive vulnerability here.
Yeah, it changes the whole geometry of the surgery.
And it isn't just an issue when you're placing massive implants like an AUS, right? Even in outpatient injection therapies, say someone is delivering a platelet-rich plasma or a stem cell suspension into the tissue, the guidelines literally strictly forbid injecting at 12 o'clock.
They do. And that adds a second anatomical landmine to the equation, really.
Oh, there's more.
Yeah, because directly above that rigid 12 o'clock tether point lies the dorsal neurovascular bundle.
Which is what exactly?
It's basically the primary highway of nerves and veins in that area. So if your needle trajectory drifts even slightly too deep at 12 o'clock, you aren't just risking a urethral perforation.
Oh, wow.
Yeah, you're going to compromise that entire vascular bundle.
So you could cause permanent nerve damage just by missing by a millimeter.
Exactly. And just as a quick side note, they also strictly avoid 6 o'clock because of the urethra itself in certain penile injections.
Which is why the protocols aggressively steer you toward, 10 o'clock and 2 o'clock.
Precisely. You are forced to work around the rigid points and those vascular highways.
You have to ride the anatomical curves, basically.
You do. Recognizing that strict limitation at 12 o'clock fundamentally dictates how a urologist has to maneuver. You simply cannot take a direct 90-degree approach in these spaces.
Which brings us to the actual mechanics of microinjections. Because, if a direct approach at 12 o'clock causes catastrophic damage, how on earth are they injecting bulking agents directly into the urethral submucosa without just blowing a hole straight through the wall?
It sounds impossible.
We're talking about paper-thin tissue here. Here's where it gets really interesting for me.
Yeah, this is where we get into the incredibly precise microgeometry of what they call the tissue tunneling technique.
The tissue tunneling technique.
Right. So when they are treating something like stress urinary incontinence, for example, using bulking agents like macroplastique or Bulkamid or URYX,
Yeah.
The goal is to bulk up the submucosa just under the skin of the urethra to improve coaptation.
Right.
But accessing that layer safely is just a masterclass in controlled trajectory.
Because they can't just poke the needle straight in, obviously. The guidelines specify this wild maneuver where the initial entry must be at a highly oblique 30 to 45-degree angle.
Right, you don't just jab it in. They engage the mucosa at 30 degrees, but they only advance the needle exactly 0.5 centimeters.
Half a centimeter, that is nothing.
It's tiny. And with many of these specialized delivery systems, the needle actually has a physical visual marker etched onto the metal right at that half-centimeter point, so they know when to stop.
So they hit that tiny little mark, and then they have to completely change the geometry of the instrument. They drop the angle of the entire cystoscope and the needle down to exactly 0 degrees.
Yes, they pivot so it's perfectly parallel with the urethral lumen, and, only once they are at true 0 degrees do they advance the needle the remaining 0.5 centimeters.
So they are essentially digging a horizontal trench inside the tissue.
That's exactly it. They create a tissue tunnel. This ensures the bulking agent is deployed parallel to the lumen, safely trapped within the submucosal space, rather than risking a perpendicular perforation right through the muscle layer.
Wow.
And there is a highly specific detail regarding the needle bevel, too.
The bevel, you mean like the slanted opening of the needle tip?
Exactly. It must always face inward, directly toward the center of the urethral lumen.
Wait. How is a surgeon accurately judging a 30-degree entry drop down to a true 0-degree pivot while simultaneously managing bevel orientation inside a tiny tube?
It's a lot to juggle.
I mean, that sounds completely impossible without some serious mechanical assistance.
Well, you're right. They aren't doing this purely by naked eye. They rely on rigid cystoscopes, typically utilizing 0, 12, or 30-degree lenses to optimize the visual field.
Oh, okay, so the lenses help them see the angles better.
Right, but the real mechanical advantage comes from specialized rotatable sheaths, like the ones used in the bulkhead system.
Oh, yeah, the fluid dynamics of those sheaths are fascinating. They utilize this dual valve system, right? Like a blue valve for inflow and a red one for outflow.
Yes, exactly. By maintaining continuous water inflow with the outflow closed, they artificially dilate the urethra.
So it balloons out a bit.
Yeah, and this fluid pressure gives them a pristine field of vision. The surgeon then presses the bevel of the scope gently against the urethral wall to create this temporary mucosal shelf.
A shelf, what does that do?
It effectively flattens out the curve of the tissue just enough to execute that initial 30-degree entry angle safely.
Okay. And then the rotatable sheath essentially locks the needle into specific predetermined clock positions.
Yes, deliberately avoiding 12 o'clock, obviously.
Right, aiming for like 2, 4, 8, and 10 o'clock to create a uniform cushion of the bulking material.
And the visual feedback during the injection is instant, which is crucial.
What do you mean? What are they looking for?
Well, if your 0-degree tunnel is too shallow, you'll see the mucosa immediately blanch white as the fluid gets trapped right against the surface.
So it turns white if you're too shallow.
Right, but if you've gone too deep and breached the muscle, you won't see any mucosal bulging at all. The material just dissipates into the deeper tissues.
So it's basically a Goldilocks situation. You have to be right in that perfect middle layer.
Exactly. And once you're perfectly positioned in that tunnel, the patience required is staggering.
Right. The guidelines for URYX, for example, mandate an injection rate of just 1 milliliter per minute.
1 milliliter, which is an absolute eternity when you're actively holding an instrument completely still in the OR.
Oh, I can't even imagine. But you cannot rush the fluid dynamics.
You really can't.
Why? Like, what actually happens if they try to push it faster? Let's say a surgeon gets impatient.
Well, URYX isn't just a simple fluid, Yeah. It's a polymer mixed with a carrier solvent. If you spike the injection pressure by pushing the plunger too fast, the kinetic energy forces the material to take the path of least resistance.
And what's the path of least resistance?
Right back out the puncture hole you just made.
Yeah.
You induce material reflux.
So you literally watch your expensive implant leak away right before your eyes.
Exactly. So you have to push in an agonizing crawl. And even when the injection is complete, you can't just withdraw the needle.
Wait, really?
Nope. You have to hold it dead still in the tract for 30 to 60 seconds.
Just freezing there for a whole minute. I would assume that's just to let the tissue pressure equalize or something.
It's more than just pressure equalization. It's actual chemistry happening inside the body.
Really?
Yeah, that 60-second hold allows the carrier fluid to begin dissipating into the surrounding tissues. As the solvent leaves, the polymer precipitates and solidifies into a cohesive, spongy mass.
Oh, so it cures in place.
Basically, If you pull the needle before that solvent exchange happens, the liquid polymer just tracks right back out of the tissue tunnel.
Wow, so that's the microgeometry managing half-centimeter tunnels, 30-degree pivots, and the fluid dynamics of polymer precipitation. It's mind-blowing.
It is incredibly precise.
But what happens when we scale this up? Because tunneling half a centimeter under direct visualization with a scope is one thing,
Right.
but when a surgeon has to bypass the urethra entirely and drive a huge delivery needle deep into the pelvic, like during a sling procedure, they lose all that visual feedback, right?
They absolutely do. They are effectively flying blind.
That sounds terrifying.
It's a massive shift in spatial reasoning. So when placing a sling, using something like the ARC system by Lena Medical, surgeons are manipulating these large, curved delivery needles that have to aggressively puncture through the endopelvic fascia.
And you have zero direct line of sight while doing this. But if they can't see, how is that not just wildly dangerous? If you misjudge the trajectory by a few degrees, you're going right through the bladder.
Well, it becomes an exercise in tactile geometry.
Tactile geometry, so mapping by touch.
Right. To avoid the bladder and the fixed sections of the urethra, the surgeon has to physically insert their index finger to palpate the edge of the pubic bone.
So they're using the pubic symphysis as like a fixed hard coordinate.
Exactly. In a pelvic space where all the soft tissues are pliable and shifting around, that bony edge is your only reliable anchor point.
That makes sense.
You triangulate your position in three-dimensional space based purely on where your finger is resting against the bone.
And the required trajectory to pass the needle from that anchor point is incredibly specific.
Very specific.
When making that initial puncture through the fascia, they have to aim the needle directly toward the ipsilateral shoulder, right?
Right. So if you are driving the needle on the patient's right side, the trajectory is angled straight up toward their right shoulder.
But the absolute microsecond, they feel the pop of the needle breaking through that tough fascial layer, they have to violently alter the trajectory.
They do. They have to pull up to point straight superiorly toward the suprapubic exit site.
Because if you maintain that initial shoulder trajectory for even a fraction of an inch too long after breaching the fascia,
you will crash the needle right into the bladder wall or the urethra.
it's literally a slingshot maneuver.
Yes.
Like a spaceship doing a slingshot maneuver around a planet. You aim right at the gravity or the shoulder trajectory just to break through the resistance of the atmosphere. But the instant you clear it, you pull violently up to avoid crashing into the planet's surface, the urethra.
That is a perfect analogy. And what's fascinating here is how the human body's anatomy forces surgeons to use these complex nonlinear trajectories.
Right, you can't just draw a straight line.
No, you cannot push a needle from point A to point B. The physical structures force you to execute these multiplanar curves. You have to ride the anatomical curves.
And even with flawless tactile feedback on the pubic bone, they don't trust it blindly.
Definitely not.
The protocols mandate that immediately after placing those needles, the surgeon has to drop everything and perform a full cystoscopy.
You have to visually verify the integrity of the structures. You pass a camera into the bladder to ensure that during that violent slingshot pivot, you didn't accidentally clip the bladder mucosa or the urethra.
Which begs the obvious question, what happens when the slingshot fails? Or worse, what happens when a doctor tries to navigate these spaces without the modern rotatable sheaths and visual checks?
Well, the historical context is pretty grim, honestly.
Yeah.
And it highlights exactly why these strict protocols exist today.
Tell me about it.
Before we had widespread, high-definition cystoscopy, doctors relied heavily on metal urethral dilators, things like Van Buren or Bernicke dilators.
Okay, what are those?
They are basically rigid, curved metal rods used to stretch out urethral strictures.
And those are pushed entirely by feel.
Entirely tactile. And because you are pushing a rigid metal curve through a delicate, highly vascularized tube, the risk of creating a false passage is notoriously high.
A false passage. Walk us through the physics of that. How does a false passage actually happen?
It's a failure of trajectory matching.
Okay.
If the metal curve of the dilator doesn't perfectly match the anatomical curve of the patient's urethra, especially as it bends around the pubic bone, the tip of the metal rod catches the mucosa. And because the surgeon is applying forward pressure, the rod shears right through the urethral wall and carves a brand new, completely incorrect tunnel straight through the surrounding spongy tissue.
Oh, that is catastrophic. You're literally tearing a new bleeding tunnel through the pelvis just because the geometry was off by a few degrees.
Exactly. And that kind of blind, brute force error is exactly what modern microtunneling and visually guided sheaths are designed to completely eliminate.
I can see why.
But even with modern tools, if we go back to the AUS implant we started with, geometric failures still occur.
Right, going back to that 12 o'clock danger zone.
Yes, if a surgeon misjudges their depth and perforates the urethra at that rigid 12 o'clock position during an AUS placement, the consequences are immediate and severe.
Because, I mean, you can't just throw a suture in a 12 o'clock tear and continue placing the sphincter cuff over it, right?
Absolutely not. A perforation during an AUS placement is an immediate hard stop.
You just abort the surgery.
The surgery is aborted. Usually, the surgeon will see a sudden wash of clear fluid or contrast dye leaking into the operative field, which is the undeniable visual signal that the mucosal integrity is breached.
So what's the protocol then? You abort the surgery, and then what do you do with the patient?
You immediately place a Foley catheter to decompress the bladder. You have to divert all the urine pressure away from the injury so the tissue has a chance to rest and heal.
Okay.
But the most punishing consequence is the timeline.
How long?
That patient requires a minimum of 3 months of healing before you can even consider reattempting the AUS placement.
Wow. 3 months just to try again?
Yeah. And that is assuming they actually spot the leak in the OR.
Oh, wait. What happens if a microperforation at 12 o'clock goes completely unnoticed and they leave the AUS implant fully installed?
That is the absolute nightmare scenario. If you place the artificial cuff directly over an unrecognized 12 o'clock tear, you are basically setting a trap for tissue necrosis.
Because you're applying mechanical compression over a structural defect.
Exactly. The artificial cuff is designed to squeeze the urethra to prevent leaks.
Right.
But if it's squeezing against a wall that is already compromised by a tear, you completely destroy the microvasculature in that tissue. The blood supply is choked off, the tissue becomes ischemic, and it literally dies.
That's horrifying.
It results in early cuff erosion, where the implant basically eats its way right into the urethral lumen.
It's like leaving a fractured steel beam inside a load-bearing wall. Eventually, under the daily stress of the structure, the entire system just collapses.
That's exactly what happens.
Yeah.
And this raises an important question for anyone looking at these guidelines. It highlights why those old blind procedures are considered so antiquated.
The margin for error is just too small.
Way too small. And the tissue at 12 o'clock is simply too rigid to rely on tactile feel alone.
So what does this all mean for us? I mean, it's fascinating because it completely reframes what we think of as surgery. We started this deep dive thinking about, biology and medication, but these urological procedures are truly master classes in applied physics.
They really are. I mean, it's fluid dynamics when you are managing the solvent exchange of a polymer at 1 milliliter per minute.
Right.
It's spatial reasoning when you are triangulating your trajectory off the pubic bone to execute that slingshot maneuver around the bladder.
And it all hinges on respecting that structural vulnerability at 12 o'clock. You have to master a 30 to 0 degree microtunnel just to safely inject a few drops of hydrogel without breaching the wall.
And it leaves you with a really compelling thought about where this is all heading.
Oh, yeah. Like what?
Well, right now, executing a perfect 30-degree entry angle or judging the exact pivot point for an ipsilateral shoulder trajectory relies heavily on the physical feel and spatial intuition of a human hand.
Yeah, it's basically an art form based on thousands of hours of repetition.
Exactly. But as medical technology advances, we are rapidly approaching an era of real-time 3D spatial mapping and robotic assistance.
Oh, wow.
Imagine a surgical environment where the exact rigidity of the 12 o'clock corporate tether is mapped digitally.
Like a GPS for the urethra?
Yeah. And a robotic system calculates that precise 30 to 0 degree drop without any risk of human tremor or visual misjudgment.
That would change everything.
If human hands are navigating these fractions of a millimeter this well today, just imagine how much safer and more efficient these procedures will become when the risk of human geometric error is mathematically eliminated.
That is wild. It makes you wonder what other invisible, highly engineered scaffolding is hiding inside us, just waiting for the right technology to map it out. It's a completely different way to look at the human body. For everyone listening, keep questioning the mechanics of the systems around you, and we'll see you on the next deep dive.